Hello students. In this session we will talk about the radiology and living anatomy related to upper limb. The competencies of this session are: identify the bones and joints of upper limb seen in the anterior, posterior and lateral view radiograph of shoulder region, arm, elbow, forearm and hand. Identify and demonstrate important bony landmarks of upper limb, which include jugular notch, sternal angle, acromial angle, spine of scapula, vertebral level of medial end, inferior angle of the scapula. Identify and demonstrate surface projection of cephalic and basilic vein, palpation of brachial artery, radial artery, testing of muscles, trapezius, pectoralis major, serratus anterior, latissimus dorsi, deltoid, bicep brachii, and brachioradialis. The learning objectives of this session will be that by the end of the session, all of you must be able to explain the skyagram in terms of type of skyagram, which means either plane or contrast, view, which means AP view, PA view, lateral view, or oblique view, region. In this session, we will talk about shoulder region, elbow joint with arm and forearm, wrist joint with forearm and hand, and explain that what does the skyagram shows. You all must be able to identify the bones in the skyagram. You must be able to show the borders, angles, and processes of different bones. You must be able to identify and name the joints seen in the skyagram and identify the bones forming the joint. You must be able to identify jugular notch, sternal angle of Lewis, acromial angle, spine of scapula, vertebral level of the medial end, and inferior angle of the scapula. You must be able to identify and demonstrate surface projections of cephalic vein and basilic vein. You must be able to enumerate the sites where peripheral pulses can be palpated in upper limb, and this is quite significant for you as a first year student. You must be able to enumerate the point to demonstrate the way of palpation of radial artery and brachial artery. You must be able to enumerate the points to demonstrate the way of testing following muscle, which are trapezius pectoralis major, serratus anterior, latissimus dorsi, deltoid, bicep brachii, and brachialis. You all are aware about the spectrum of light rays. Out of all the electromagnetic radiations, X-ray are used in medical field for diagnostic and palliative, that is, curative purposes. These X-rays have penetrating property. When the X-rays are made to pass through the human body, a part of the X-ray may get completely pass through from the human body and may reach photographic film. These rays, which completely pass through the human body, they impart black color on the photographic film. However, a part of the X-ray may get obstructed on their way, which may either be because of the absorption of the rays by the human tissue or scattering of the rays. So, when these rays with the reduced intensity, they reach the photographic film, they impart opaque or translucent image on the photographic film, which we say as white image on the film. Now let us try to understand this again in this slide. Suppose this is a photographic film and this is the source of X-ray beam, and this is the subject which has to undergo X-ray. So when the X-rays, they are projected on the subject, what are the fate of these X-rays? These X-rays may either completely pass through the human body and may reach photographic film. When this occurs, black shadow is imparted on the photographic film. Some of the X-rays, while passing through the human body, may get either absorbed or scattered on their way before they reach the photographic film. When these rays with the reduced intensity, they reach the photographic film, they impart white shadow on the photographic film. Now on your screen on the right side, you can see a X-ray there Here, this black shadow is because of the complete penetration of the X-rays, and this white shadow is because of the incomplete penetration of the X-ray beam. Now, before going further ahead, let us add on a term in your dictionary, which is skyagram. What do we mean by skyagram? When we say skyagram, it means a photographic image produced on a radiosensitive surface by X-ray. Skyagram is nothing but what you commonly call as X-ray. Remember, X-rays are the electromagnetic waves, but the X-ray which we get from the hospital, the plate, it is very wrongfully called as X-ray. Rather, it should be correctly called as skyagram. So in this session, we won't use the term X-ray for the photographic film. Rather, we will use the term skyagram. As a medical student, you must know how to read a skyagram, which means that after seeing a skyagram, what all are the points you need to cover in order to completely describe a skyagram. So, the points which you must need to cover are, you must start with what is the type of skyagram is it? Is it a plane or a contrast skyagram? Plane and contrast means in contrast skyagram, a radio contrast dye is injected in order to outline the anatomical structure. And when the X-ray is taken or when the procedure is done without injecting the radio contrast dye, it is called as plain skyagram or the plain X-ray. Then second thing you need to comment is upon the view, which means whether it is antero-posterior view, whether it is posterior-anterior view, whether it is lateral view or oblique view. View means in which direction the X-rays were projected, the waves were projected, whether they were projected on the body from the anterior to the posterior side. This means the X-ray beam, the source of the X-ray beam. When we say antero-posterior view, this means the source of the X-ray beam was placed anteriorly and the photographic film was placed posteriorly. That is posterior to the subject's body. And the direction of X-rays were anterior to posterior. When we say posterior-anterior view, this means the source of X-ray beam was posterior to the body and the photographic film was placed anteriorly. And the direction of X-ray is from posterior to anterior side. When we say lateral view, this means the X-ray source was on one side, either left or the right side of the body, and the photographic film was on the opposite side. And the X-rays were projected on the body from side to side. Obliquely means not antero-posterior, not posterior-anterior, not lateral to lateral, rather in an oblique plane. So, depending upon the direction in which X-rays proceeded in order to reach the photographic film, we label the X-ray as which view is it. That is, the view which we define is nothing but the direction of X-rays in which X-ray traveled. The third thing you need to emphasize is upon the region. The skyagram is showing which region of the body. As in case of upper limb, we will see the skyagram of shoulder region, elbow joint with lower part of the arm and upper part of the forearm, wrist joint with the lower part of forearm and hand. And the last thing which you need to comment is what is the skyagram showing. So the 4 points which completely describe the skyagram are, you must start with the type of skyagram, view, region, and what does the skyagram exactly shows. On your screens you can see 3 different skyagram of 3 different regions in the body. On the leftmost side you can see the skyagram of thoracic cage in the center of the abdominal cavity, and on the right side the skyagram again of the abdominal cavity with the pelvic cavity. The leftmost skyagram showing the thoracic cage, it is the example of plain skyagram. There is no any radio contrast dye injected to take this skyagram. However, the other 2 skyagram, the radio contrast dye has been injected in order to enhance the outline of GI tract
in the center Skyagram, and in order to enhance the urinary tract in case of right side Skyagram. So you can clearly see that how does the contrast X-ray or the contrast Skyagram looks like.
Now, after learning about how to explain a skyagram, now let us start with the first skyagram. On your screen, you can see a skyagram of shoulder region. Now, how will we explain this? The correct way to explain it is, this is a plain skyagram, posterior-anterior view of shoulder region left side showing clavicle. This is the medial end of clavicle. This is the lateral end of clavicle. This is spine of scapula, which is becoming continuous with the acromial process. This is tip of coracoid process. This is glenoid cavity. This is lateral border of scapula. Now, this is head of the humerus. This is the surgical neck of the humerus. This is shaft of the humerus. Now let us trace the anatomical neck of humerus. So this is anatomical neck of humerus. This is greater tubercle of the humerus. Now, on the skyagram present on the right side of the screen, you can see lateral border of scapula here. You can also see superior border of the scapula here. This is superior border of scapula. Now you can trace the superior angle of scapula here.
The Skyagram present on the left side of the screen shows the medial border of scapula. Now, after seeing all this, I commented that this is a posterior-anterior view of the shoulder region. Why did I say posterior-anterior view? Because whenever the X-rays are passed in any direction, the part of the body which comes first, that is the bones, either on the anterior side or on the posterior side of the body, whichever bones come first on the way of the X-ray will impart a brighter shadow on the skyagram compared to the bones which comes later. For an example, in posterior anterior view, the direction of X-ray is from posterior to anterior side of the body, and hence the bones which are present on the posterior side of the body wall, which are vertebral column, scapula, posterior end of the ribs, they will impart a brighter shadow on the skyagram compared to the bones which are present on the anterior side, which are clavicle, sternum, and anterior end of the ribs. And hence, by seeing these, I commented it is a posterior anterior view of the shoulder region.
Let us start with next skyagram. This diagram which is there on your screen is of elbow joint. Before going ahead, let me tell you the most preferred view in case of elbow joint is antero-posterior view, and it is sometimes referred to as posterior-anterior view as well. It is very difficult to say whether it is antero-posterior or posterior-anterior view in case of elbow joint, and hence we have to memorize this, that in case of elbow joint the most preferred view is antero-posterior view, and hence while describing this skyagram I will use the reference as antero-posterior view. So let us start with this skyagram. This is a plain skyagram, antero-posterior view of elbow joint showing the shaft of the humerus along with the lower end of the humerus showing medial epicondyle, lateral epicondyle. This is olecranon fossa and this is trochlea. This is coronoid process. This is capitulum and this is head of radius. This is neck of the radius. This is radial tuberosity. This is shaft of the radius and this is shaft of the ulna.
The next diagram is of the wrist joint along with the lower end of radius and ulna. Now let us learn how to describe this X-ray or this diagram. This is a plain diagram AP view of wrist joint along with the lower end of radius and ulna, showing the lower end of the ulna, where we can see this is the lower end of the radius. Over the lower end of the ulna, we can see this is head of the ulna. This is styloid process of ulna. Likewise, over the lower end of radius, we can see this is styloid process of the radius. Then, about the carpal bones, let us learn how to identify the carpal bones. But prerequisite is that you must be thorough with the arrangement, the sequence of the arrangement of carpal bones in proximal and distal row from lateral to medial side. It should not be haphazard that you are numbering or you are identifying the carpal bones anywhere. The protocol is you must identify the carpal bones first in the proximal row from lateral to medial side, and then in the distal row from lateral to medial side. So let us identify the carpal bones here. I am proceeding in the proximal row first from lateral to medial side. Now how will I identify which one is the lateral side? I will either see the first metacarpal, or I can also see the lower end of radius and ulna. So the wider bone is the radius and the narrower bone is the ulna. The lower end of the radius is wider and the lower end of ulna is narrower. So this is the lateral most carpal bone in the proximal row, and this is scaphoid. Next to scaphoid, that is for the medial to scaphoid, we have lunate. Now you can cross check your identification by seeing that the scaphoid and the lunate, they are articulating with the lower end of the radius in order to form the radiocarpal joint. So in this Skyagram, yes, they are articulating with the lower end of the radius. Now over the scaphoid, you can see a white color ring here, this ring. This is the margin of the tubercle of the scaphoid. Further proceeding medially, the next bone is triquetral. Over the triquetral, we have pisiform bone. Now the point here to remember is scaphoid, lunate and triquetral, they are placed side to side from lateral to medial, but pisiform is placed on the ventral surface of the triquetral bone, and hence the shadow imparted by the pisiform bone overlaps the shadow imparted by the triquetral bone. This you need to remember, and hence in this Skyagram you can see the pisiform overlapping the triquetral. So we are done identifying the carpal bones in the proximal row. This is the pisiform. So now let us start the carpal bones in the distal row. We will again proceed from lateral to medial side. So the lateral most bone is this. This is trapezium. Going further medially, this is trapezoid. Further medially, this is capitate. And most medially, we have got hamate. Now over the hamate, you can again see a bright color, a white color ring here. This is the hook of hamate, the outline of the hook of hamate. Now this is the base of the first metacarpal, this is the base of the second metacarpal, third metacarpal, base of the fourth metacarpal and base of the fifth metacarpal. This is the shaft of the first metacarpal, second, third, fourth and fifth metacarpal. Now in this illustration you can see this is the head of the metacarpal and this is the phalanx. So this is the proximal phalanx, this is the middle phalanx and this is the distal phalanx. You can also appreciate that in the first digit, that is thumb, we have only proximal and distal phalanx. Middle phalanx is not present in the first digit. Now in this Skyagram you can also see a sesamoid bone other than pisiform. This is a sesamoid bone which is present in the tendon of flexor pollicis brevis. This is often seen and hence you need to remember this. So at this point of time, let us quickly revise the characteristic feature of a sesamoid bone. Sesamoid bone, as you can see, this is a sesamoid bone and now you know that it is formed in the tendon of flexor pollicis brevis, and other sesamoid bone present in this Skyagram is pisiform bone. So in hand, you can very often, you will always see one sesamoid bone which is pisiform, and very often you can see the sesamoid bone present in the tendon of flexor pollicis brevis. So let us quickly revise the characteristic feature of a sesamoid bone. Sesamoid bone ossifies in the tendon of a muscle. It has no periosteum, it has no blood supply of its own. It derives its blood supply from the muscular arteries, the adjacent muscular arteries. It has no medullary cavity and it acts as a pulley for the tendon.
Now let us start with the living anatomy. The surface landmarks had been already covered with respective regions, so we will focus on those parts which were uncovered earlier. In this illustration, to summarize, this is clavicle. This is medial end of the clavicle which bounds the suprasternal notch, also called as jugular notch. This is sternal angle of Lewis, which lies at the level of second rib, or I may say the anterior end of the second rib articulates with the sternum at the level of angle of Lewis. This is the lateral end of the clavicle which articulate with the acromial process, and you can see this is the highest point of the shoulder region which is formed by acromial process. This depression is deltopectoral triangle. Just lateral to it, 2.5 centimeter below the clavicle, we have tip of coracoid process. This is scapula. This is inferior angle of scapula which lies at the level of 7th rib. This is apex of the spine of scapula. It lies at the level of 3rd rib. A very frequently asked question from a first year medical student is to enumerate the sites where peripheral pulses can be palpated. As of now, we will talk only about the sites where peripheral pulses can be palpated in the upper limb. The most frequently palpated artery is the radial artery, and this radial artery, it is palpable over the volar aspect of the wrist, that is anterior aspect of the wrist in between the tendon of flexor carpi radialis medially and radial styloid process laterally. So this is the site where radial artery is palpable. Second most frequently palpable artery is the brachial artery. Brachial artery, the pulsation of the brachial artery can be palpated in the arm and in the cubital fossa. So in the arm, it is palpable in the groove between the coracobrachialis and bicep brachii muscle, whereas in the cubital fossa, it is palpable medial to the tendon of bicep brachii. The next artery which is occasionally palpable is axillary artery because it can be palpated on deep palpation against the head of the humerus. Pulsation of the ulnar artery can also be felt on deep palpation. And where can we feel the pulsation of ulnar artery? The pulsation can be felt lateral to the tendon of flexor carpi ulnaris at the level of wrist. Now let us learn how to mark cephalic vein on the surface. There are 2 points defined. Point 1 lies in the deltopectoral groove just below the coracoid process. Point 2 is in front of the elbow in the groove between brachioradialis and bicep brachii. Now we have to join point 1 with the point 2 with a line which first ascend up and then arc towards the first point with the convexity upward. This is the surface landmarks, the point for the surface landmark for cephalic vein. About the basilic vein, the 2 points are defined. First point is over the upper end of the arm, midway between axilla and medial condyle. So this is the first point. The second point is over the anterior surface of the forearm below the elbow joint, and now the point 1 and the point 2 has to be joined with a straight line. This straight line represents the basilic vein. Now let us learn how to test various muscles in the body. The principle is that in order to check the integrity of any muscle, we ask the subject to perform movement which a particular muscle is responsible to produce, and this movement has to be performed against resistance. For example, in order to check the integrity of trapezius, specifically the upper fibers of trapezius, when we ask the person to shrug the shoulders against resistance. If he is able to do so, this means the upper fibers of trapezius are intact, that is functioning normally. The lower fibers of the trapezius can be tested by asking the subject to perform scapular retraction. Likewise, latissimus dorsi, it is responsible to cause adduction at shoulder joint, and hence the person or the subject can be asked to perform adduction of the arm against resistance. Bicep brachii can be tested by asking the subject to perform flexion at elbow joint against resistance when the forearm is in supinate position. Brachioradialis can be tested again by asking the subject to perform flexion at elbow joint, but in this case, the forearm should be in mid-prone position. Deltoid can be tested by asking the subject to perform abduction at shoulder joint. Pectoralis major, specifically the clavicular fibers of pectoralis major muscle, can be tested by asking the person to perform flexion at shoulder joint against resistance. The sternoclavicular head can be tested by asking the subject to perform adduction at shoulder joint against resistance. Serratus anterior. It can be tested by asking the person or the subject to perform pushing and punching movement and then seeing whether the medial border and the inferior angle is becoming prominent or not. If the medial border and inferior angle becomes prominent on performing pushing and punching movement, this indicates the paralysis of serratus anterior muscle is there, and if the medial border and inferior angle they do not become prominent, this means the serratus anterior muscle is intact. So with this we end up this session. Thank you.